So we'll work, kind of like we've been doing, right? We'll partially fill these in as we talk, and then whatever's left over is you'll owe me the next time we meet. Good. So humerus and shoulder girdle. So now we're above the elbow. But of course, as we know, any long bone we're supposed to demonstrate will also include the joint space accompanying that bone, right? So we'll still include the elbow when we discuss the humerus, but we're done with those specialty elbow positions now. So what do we mean by shoulder girdle? What do we mean by humerus, right? The humerus is the long bone of the upper arm. So we zoom in on this image here, right? And we see the single long bone comprising the upper arm. Distally, the humerus creates the shoulder joint with the radius and ulna, and proximally, the shoulder, the humerus creates the, did I say shoulder joint? Distally, the humerus creates the elbow joint with the radius and ulna, but I didn't misspeak, and proximally, the humerus makes the shoulder joint, okay? You'll notice that the shoulder joint does different things than the elbow joint does, right? The elbow joint has this sort of hinge-like movement, right? We have flexion extension of the elbow given by our ulna and humerus. We also have pronation, supination of the forearm, hand and wrist as well. But up at the shoulder, we have a ball and socket type joint, okay? The humerus gives us the ball, the head of the humerus, and the scapula gives us the socket, the thing that the ball fits in. We have another one of these down in our hips too, right? Our femur and pelvis give us the ball and socket joint of the lower extremity. And this joint allows us to circumduct. Circumduction is where you can take a body part, like a finger, for example, and wiggle it around like a cone shape, right? You can do that same thing with your shoulder. Okay, so lots of movement, lots of extra movement that our shoulder gives us that other joints don't. The shoulder girdle is made up of 3 bones. You have the humerus, the scapula, and the clavicle. Upper arm, shoulder blade, collarbone. Let's look at some of the pertinent anatomy of the humerus, and I think the way the PowerPoint is structured, we're going to basically stick proximally. We did a lot of work on the distal humerus last time, right? The condyles, the trochlea, the capitulum, right? We did a lot of work on those distal humerus structures. Now we're going to again work up towards the top. The middle of the humerus is not too impressive, right? It's the body or shaft or diaphysis of the bone, long and narrow. Either end has the important stuff. That's where the joints appear. So, proximal humerus anatomy. Let's jump into this. Okay. So we'll start distally with the body or shaft, or again, diaphysis. And then we notice this, by the way, this position that they have us in is what we'll call an external rotation position, or said in another way, it's like an AP, anterior view of the humerus. The patient has their palm turned out towards us, okay? And so we see the head of the humerus pointing to the right on the screen. I'm pointing to your left, but you get the idea. It's going this way on the screen, right? Medially towards the patient, and the lateral aspect of the humerus is pointing laterally. Okay. With that said, what we're seeing right now is the front of the humerus. Okay, and on the front of the humerus, there are some important structures. First is, as we move up the shaft and we get towards the proximal humerus, we have this little ridge called the deltoid tuberosity. Okay, this has to do with a muscle in the upper arm, the deltoid muscle. As we move up higher, we notice that there are 2 more tuberosities, and tuberosities are sort of like these protrusions from a bone. Okay, so we'll use that term tuberosity. We've got a greater tuberosity laterally. This is this ridge here, and all of this in profile. And then we have a lesser tuberosity. By the way, tubercle is another appropriate name. So you see them say tubercle, and in parentheses, tuberosity. Interchange those freely. In the middle of these 2 tubercles or tuberosities is a depression, a long, narrow valley. Okay, so you think about these like mountains, right? The tuberosities like mountains, and in between these 2 mountain ranges is this narrow valley. This is the what's called the bicipital groove. This has to do with biceps tendons. Okay, so bicipital groove here. The humerus and the femur share some things in common, right? The femur in the lower extremity's got a head, the humerus has a head, the lower extremity femur has two necks, and so does the humerus. So remember this stuff when we get into the lower extremity parts, okay? But you'll notice we have a labeling here called surgical neck, and up here something called anatomic neck. Surgical neck is for surgeries. Anatomic neck is the part on the anatomy that is what we'll refer to as truly the neck of that bone. This is the division here, if I zoom in a little bit, where they say anatomic neck and they point to it. It's the division between metaphysis, where the bone begins to flare, right? And epiphysis, which is the end of the bone. Okay? The anatomic neck is really what the anatomic neck is the epiphyseal plate. But it is important to remember there's a surgical neck and an anatomic neck to both the humerus and the femur. And then of course we have the head of the humerus, making the ball for the ball and socket joint. So those are our important anatomic structures. These are visible on the external rotation view of the humerus, especially the greater tuberosity. We see this in good profile when we do this position. Let me show you a radiograph.
You said the head part is the epiphysis?
The head is the epiphysis, yeah. Okay. Epiphysis or epiphysis, yep. Good. Sometimes I overpronounce and I say epiphysis so that we can hear the different word parts, but most people will just say epiphysis, which is, and both are fine.
Okay.
Yeah. Okay, so labeled B on this drawing, I say drawing, labeled B on this radiograph, okay, because there's a bunch of drawings. Labeled B on this radiograph is the greater tuberosity or tubercle. That is an important structure and radiographically because it lets us know when we can see the shape, that sort of squared off shape of the, it's still big enough for you guys to see. If I put my laser pointer up here, you kind of see how this kind of is a square upper edge to the humerus. This point right there, right? That square upper edge to the humerus tells us that we're in external rotation. Like when you look at a shoulder, the reason why I could go right up to this one, and I know this patient here was in external rotation, is because I can see this greater tubercle, this sort of squared off protrusion, okay? That goes away in the internal rotation view of the shoulder, because they're changing the relationship of that bone, they're turning that bone. So it's an important thing. It's like you can tell they're in external rotation very quickly if you can see that square upper edge to the humerus. Okay, let's look at our next thing. Are we skipping? Okay, I guess we're just doing the easy stuff first. Okay, so the next thing to look at of the shoulder girdle, we did the proximal humerus. Now let's jump to the clavicle. Nothing too crazy with the clavicle. It's another long bone of the body. It has an epiphysis on either end, a body or shaft, or diaphysis if we're using those terms. But importantly, the clavicle makes two bony connections, okay? One of them is, of course, medially at the sternum. So we make what's called the sternoclavicular joint, right, where the laser pointer is indicating here. Sternoclavicular joint, or SC joint for short. That's proximal, or let's say medial on the clavicle. Lateral on the clavicle, we have the acromioclavicular joint, or AC joint. Now here's the important thing about the clavicle. The clavicle is the only bony connection for the shoulder girdle to the body. Think about your arm, right? It doesn't attach by bone to your body except for the sternoclavicular joint. Your scapula is not connected to bones. Your scapula sits on top of muscles, right? your humerus is attached to the scapula, which is not attached to any bones, right? Except for the clavicle. The clavicle is your only bony connection to the body for your upper extremity. This is why it's so important when it breaks, right? We sort of lose all function, right? Think about it like this, right? When you go to push something away from you, okay, do anything with this upper extremity, you have your pectoral muscles that flex and try to pull your whole shoulder inward, right? And what's your clavicle do? Your clavicle sits there and pushes away, pushes outward, keeps the whole shoulder from collapsing inward towards the body because it's not connected to any part of the body, of the torso, except for right here at the sternoclavicular joint. So your clavicle is your connection for the upper extremity to the body. And it has that hard job of pushing away while all these muscles try to pull it inward. So AC joint, we call the end of the clavicle towards the AC joint. You can call that the lateral of the clavicle, the lateral aspect, because it's towards the side of the body. You can also call it the acromial extremity, the acromial end of the clavicle. The sternal side of things, you can call that the medial aspect of the clavicle, because it's towards the midline of the body, or we can call it the sternal extremity. It's the part of the clavicle that touches the sternum. This, of course, is our sternum here. Okay. Is everyone feeling okay so far? Proximal humerus, and we have a pretty simple clavicle. Let's do the scapula now. The scapula is a different kind of bone, right? The humerus itself is a long bone. The clavicle is a long bone. The scapula is not a long bone. Okay, the scapula is classified as a flat bone. Okay, because it's a big flat bone, right? There's nothing else to it. It really is that simple. But the important thing about flat bones have no medullary cavity, so they have no hole down the center of them. They are a thin layer of compact bone, a thick layer of spongy bone, and another thin layer of compact bone. They are a spongy bone sandwich. Okay, and they're flat. That's the important part about them. Okay, so with the clavicle, the first thing that should become apparent to you, because it's a big flat bone, is that you sort of have, it's like a triangle. It's like an upside down triangle with the point at the bottom, right? The inferior angle, as we'll call it, down at the bottom. You have a medial border to the clavicle, a lateral border to the clavicle. We can call the medial border the vertebral border, and the lateral border we can call that the axillary border. Either are appropriate. And then hard to see here, but it's a little comminuted in this image. But you have the superior border to the clavicle too. This is where a lot of important stuff happens with the superior border. Let's zoom in. No, not zoom in. Let's go to the next image. Okay. So 2 ways to look at the clavicle. Well, 3 really. You can look at it from the anterior or the posterior or laterally. Okay. Well, let's just start with anterior first. This is sort of the view that you get on the clavicle when you take an AP projection of the shoulder. If the shoulder is an external or internal rotation, doesn't matter, or neutral. If you take an AP projection of the scapula itself, right? But here's our scapula. Inferior angle, medial border, lateral border, and superior border. You have a superior angle as well. These are the pointy parts, right? This is one corner of the triangle, another corner of the triangle. You notice that this corner of the triangle, the lateral corner of the triangle, there's no point, right? There's a bunch of other projections, right? Protrusions, processes, as we'll call them. So let's look at the processes first. There are 2 main processes on the scapula to take note of. One is called the coracoid process. Here's the hard thing. Don't confuse that with the coronoid process in the elbow. Okay, I know that frustrates me, and it comes up on tests too, because they're very similar. So they'll ask you about the coronoid process of the scapula, and they're expecting you to remember it's not that named that. Okay, anyways, coracoid process, and this is sort of like if you just kind of sit there, you can feel like your shoulder here, and if you just sort of push medial to your shoulder, your finger kind of falls into this little depression here between the chest and shoulder. That's right where your coracoid is. Okay, it's actually it's not a bony landmark because you can't actually touch the coracoid, but it is one of those landmarks that we use. We try to center for shoulders right around that point, like an inch inferior to it or whatever. But we try to use the coracoid as a centering for ourselves. Anyways, coracoid process. The other process that's useful to remember is the acromion process here. The acromion process makes the acromioclavicular joint with the clavicle. Acromioclavicular, acromion and clavicle. So acromion is here. The acromion is special because it forms like the roof or the top of the shoulder, right? So the humerus sits up in there, right? And the acromion keeps everything really in place for the shoulder from moving upward out of place superiorly. So this whole area here is for the humerus to fit into. Okay, so I've discussed the processes, the coracoid process, acromion process, and then let's discuss a fossa. A fossa is the name for a depression in a bone, a little indentation, or using words we should be used to by now, a concavity, right? The glenoid fossa, or glenoid cavity here, is this cup-shaped depression on the clavicle, on the scapula. Okay, this cup-shaped depression faces laterally, tiny bit of anterior tilt to it, but it faces laterally so that it can line up with the humerus and form the shoulder joint. This is the main bony joint for the bony part of the scapula that forms the shoulder joint with the humerus. Okay, the glenoid has its own little neck here, indicated by this little line pointing to this area. Okay, but that's the stuff, right? And then the anterior surface of the scapula is called the costal surface. Okay, let's go to the posterior scapula. And this is the thing, like when we do a radiograph, anterior and posterior are not differentiated. Everything's sort of superimposed on itself, right? You see anterior and posterior together, but if it's a bone you're looking at, not a radiograph, you can turn the scapula around and see the back of it. And from the back, the first thing that should become apparent is that there is this ridge or spine that runs almost horizontal from medial to lateral of the clavicle and becomes the acromion. This is called the crest of the scapular spine. So the thing is called the scapular spine. Okay. Above the spine is the supraspinous fossa. That's this big, big indentation here. Below the spine is the infraspinous fossa. Infra for below, supra for above. And spinous should make sense, and fossa should also make sense by now. Okay, and that's really the important stuff on the posterior of the scapula. So you've seen anterior, you've seen posterior on the scapula. The other way to view the scapula is laterally. And laterally, what you should notice is, what I'll tell you to notice is that it forms a letter in the alphabet. Okay, it forms the shape of a Y, right? So we get this Y view of the scapula when we look at it laterally. Okay. You should also notice that the glenoid fossa is now facing you, right? So now we're seeing the shape or the profile of the glenoid fossa. Okay. When we perform this view on a patient, we can see the relationship between the glenoid fossa and where the humerus lines up within it, right? If the humerus is below it, above it, anterior or posterior to it, we can see that when we perform this lateral projection of the scapula. You get a lateral view when you look at the scapula laterally. I keep wanting to call it a clavicle. When you look at the scapula laterally, you get a good lateral view of the body of the scapula. And of course, it looks skinny in this view, right? Because we're looking at it from the side now. This shows you just how flat it actually is. You can also see pretty clearly forming the top of the Y, the coracoid process, going to the right on the screen, and the acromion to the left. We can see that's what forms the top of the Y. We can see between the acromion and coracoid, we can see the supraspinous fossa. That's the depression in the middle, right? This whole depression in the middle, right? Supraspinous fossa. And then we can see below the spine posteriorly at the infraspinous fossa. Okay, so those three views at the bone show us everything we need. We, of course, only need an AP to see both front and back of the scapula. Okay, so that takes us through some of our pertinent anatomy here. Let's discuss some of the radiographs we're going to do. My goal, and the reason why that table's moved and this table will be cleared off eventually, my goal is for us to get some practice positioning our patients, okay? And I think what might be worthwhile prior to, let me pause this.